All right, so maybe we get started. Okay, welcome everybody. Good morning. I have the pleasure of introducing our Greenblatt Award recipient to start off. So let me tell you a little bit about Dr. Greenblatt. So the Greenblatt Award is given annually to a second-year child psychiatry fellow who best exemplifies the qualities of Dr. Greenblatt's dedication to the lives of children and families. These characteristics include deeply humane commitment to children requiring psychiatric care, exceptional talent and skill in clinical work, unusual sensitivity and concern for the needs and feelings of others, whether they be patients and families or students and colleagues. So congratulations to Dr. Gupta. Come on up here. A tireless advocate improving the lives of children. I'm going to tell you a little bit about her and embarrass her a little bit for all of you who are watching and all right here.
I'm not lying about embarrassing.
Yes, and you're going to hold the flag. Just okay, so Dr. Rahul Gupta earned her BA in human biology from Stanford University and her MS in narrative medicine from Columbia University. She went on to earn her MD from the University of Michigan Medical School in Ann Arbor. I knew it. Where she was awarded the Raymond W. Wagner Award for Distinguished Performance in Psychiatry. During medical school, she wrote about her own experience of struggling with depression as a physician trainee, publishing her essay, I Solemnly Share, in JAMA's A Piece of My Mind, and producing a short film aimed at inspiring empathy and awareness about depression among physician trainees. Dr. Gupta completed her adult psychiatry residency training here at UCLA, during which time she served as an APA Leadership Fellow, very competitive, and Quality Improvement Chief Resident with Dr. Eric Chung. She fast-tracked into the Child and Adolescent Psychiatry Fellowship. I like to say we actively recruited you, and gave birth to Benny, her now 16-month-old son, during her first year. She is now a second year serving as the CAP program co-chief with Dr. Height and pursuing the parent-infant mental health area of distinction. She's also a newly certified facilitator of the Circle of Security International Early Intervention Program for parents and children, and has begun leading Circle of Security groups in the perinatal IOP. And she's so talented beyond. After graduation, Dr. Gupta will be joining a group private practice, Adelpha Psychiatric Group, where she will work with both children and adults with a broad array of psychiatric conditions. We're so proud of her. She is so deserving. Just another round of applause. So to introduce our Greenblatt speaker, this is the infamous Dr. Stacy Drury. Infamous, more than I've known her for a very long time, and she has mentored me since I was a medical student. So this is very special to have her here at UCLA. I think she's worked with many of us here and has personal relationships because she's that kind of physician scientist. So to brag about her a little bit, Dr. Stacy Drury is a board-certified child and adolescent psychiatrist and the psychiatrist-in-chief of the Department of Psychiatry and Behavioral Sciences at Boston Children's Hospital since March 2023. It's been a year. Dr. Drury came to Boston Children's Hospital from Tulane University, where she served as the Associate Director of the Tulane Brain Institute and the Executive Director of the Tulane Violence Prevention Institute. Dr. Drury completed her BA in Religious Studies and Biology from the University of Virginia, and then went on to earn her MS in Human Genetics from the University of Michigan. She earned both her MD and PhD from Louisiana State University Health Sciences Center and completed her residency training at Tulane in general psychiatry and child psychiatry. Her clinical work focuses on medically ill children with comorbid mental illness, and her research focuses on the parent-child relationship as a critical buffer against the effects of early life adversity within and across generations. Her transdisciplinary research seeks to define the biological mechanisms through which trauma, violence, child abuse and neglect, racism, and structural inequity drive health disparities. In joining Boston Children's Hospital, she recognizes the urgent need for transformative, community-engaged, and culturally responsive efforts, targeting the prevention, treatment, and ultimately the cure of child mental illness.
Yeah, that's rare. Yeah. So I will say that I did meet Misty when she was a medical student, and her resume was already better than mine at the time. So yeah, so that was kind of like, oh, dude, how did you do that before med school? Not okay. And I will say that I have known Dr. Stuber my entire career, and she has been an incredible support through many a failed grant application. She's like, it's okay, you'll get one. Yeah, right? Repeatedly. I'll write another vote of recommendation for your third failed. So grateful for that and for letting me be on the physically ill committee forever until I finally realized I couldn't be the resident member when I was faculty. And I was like, oh, it's time to rotate off. So lots of really wonderful ties here. And I will say, I'm so sad that your news chief is not here because you guys are in such an amazing, wonderful place for having Semel come here. So I can't wait to watch her just sort of energize and bring the place to life. Not that it's not real great, but she's going to bring a lot of really wonderful, great things. So I'm very excited for all of you. All right, so here we go. So we do have funding. That's cool. Yeah. That's about all the laughter is going to happen for a while. So I tend to have like dark talks, so we'll work on that. I'm going to give sort of just bullet points about the current crisis because I really want to keep everybody talking about it, and I'm scared that there's other things in the world that people are going to be talking about, like politics. So we're not going to talk about politics. We're just going to talk about the mental health care crisis because politics is scary. And then we're going to talk a little bit about violence and ACEs, and both present behavioral data, but also present a bunch of biologic data so that you're getting that link really for like the impact of ACEs and violence. And then talk about racism as its own identifiable case, and then sort of our data from a biologic perspective as well as behavioral standpoint. And then really say, you know, how do we address this mental health care crisis as a group? I promise to end with shiny, happy stuff. I do want to start with this, and you guys can go watch this more often. This is an amazing series created by in the state of Georgia. When we think about what kids are experiencing, sometimes we need to stop, listen, and hear what they have to say. So I encourage you all to go to this webpage, but I wanted to play a little bit of this one for you.
Some things that make me afraid of an adult is like being the fear of being hit or yelled at, because those just don't work.
It really freaks me out when people start yelling, and it scares me. So I would say don't yell.
Things that make me feel unsafe are like being shot dead by the cops for no reason and dying of COVID, which is unlikely because I've been vaccinated.
Well, I'm really worried about the people doing shootings, and there's been a lot of robberies and people, like, they kill people.
I'm constantly worried about like politics kind of pulling apart our country, wars in a lot of countries that the United States is involved in, things locally, globally, nationally. I feel like it's always popping up on my phone, on the TV.
There is a lot of stuff that makes me anxious and worried in this day and age, with all of the police brutality and the Asian hate, and then just the sex trafficking. It's just, I don't feel as safe.
Whenever I go off by myself, I just sometimes feel a little nervous because I'm afraid of what might happen. Possibly like a kidnapper, maybe somebody just decided that they don't like me that much and come up to me and just pick on me for no reason.
So I think it's really important to hear what kids are saying. And what they're saying is they don't feel safe. And unfortunately, we have created that world for them. And I think it's really important that the CDC survey, so 3 out of 5 youth in the last year experienced persistent feelings of hopelessness and helplessness. 1 out of 4 seriously considered suicide. For any non-traditional, marginalized LGBTQ plus individual, the rates are staggering. 1 out of 4 attempted suicide. 1 out of 4 kids experience sexual assault. These are public health level problems. It is not something that can be solved by staying in our clinics, okay? Now we're gonna do a fun game, and most of you will get it right. Misty's not allowed to answer. When we think about the amount of time between first onset of symptoms and first contact with the mental health system, pre-COVID, anyone want to guess how many years that is? I should have said here, how long that is. Come on, somebody guess.
4?
4? Huh? What, 4, 6?
7.
7? Anyone going to higher?
10.
10. Average length of time from symptom onset to first contact with mental health provider before COVID. Now, when do we think parents first detect symptoms? If you ask them and they bring their kid to the clinic, they say, when did you first start wondering if something's going wrong? What age?
1-year-old.
Yeah, see, this is what I love about being in a place with little kids. Less than the age of 5, right? Which is really important because what was happening to our kids under the age of 6, right? In those first 5 years of life. All right, so this is dark, and I'm sorry, there will be some humor later, but I think it's really important to know that this is our current state of crisis. And we have a whole bunch of little kids that didn't have those wonderful, like, eat dirt experiences that we needed them to have, right? We didn't let them share toys or slaughter on things. We actually kept them away. I was literally wiping down the outside of potato chip bags for reasons unknown. I can't imagine having little ones, right? They didn't get to snot on anybody else, right? So, and then we put them in school. We're like, here, now you share toys. What? That was dangerous before. So I am very anxious about that group of kiddos, and I also really like them, so I'm not excited. The crisis is not new, all right? And the things that didn't cause the current crisis are COVID. It ripped a Band-Aid off a really dysfunctional system and created huge inequities in terms of educational outreach and all of those other things. Social media didn't cause it. It is not a benign thing. But this was brewing long before. And it was brewing because it is a stigmatized illness. It is brewing because we have artificially separated coverage for medical and mental illnesses, right? It's because they're carve-outs. It's because every one of our facilities is a leftover from cardiology, right? There are places that are building new wonderful campuses, but that didn't happen until about 5 years ago. Every inpatient unit I've ever worked on is a retrofitted place that does not speak to mental health. And it was somewhere that some other specialty that made money abandoned to go into the big, beautiful building. At Boston Children's Hospital, we built a $200 million Hale cardiology building. And when we did that, we took away the outdoor space and the natural lighting into our Bader inpatient unit. Not okay. And that is because we have not enforced the federal mental health parity law. We can't get reimbursed and actually work in academic settings and provide care to people and get reimbursed because there are administrative challenges to actually filing and getting it, and because it's too hard. So in Massachusetts, which is the place in the world that has the greatest number of child mental health providers per child, 40% of those providers are in private casualty practices, which then does what? Further accentuates health disparities and health inequities. And so until we address that, we are fighting an uphill battle. But it has to be something done every day, every time. We have to continue to say this is not okay. And it is not on our political campaigns at all. No one is talking about the fact that you cannot make a living as a social worker, as a clinical psychologist, as a child psychiatrist without cash. And that creates huge inequities. It creates inconsistent care, right? Because if you're in private practice, that's hard. And it shifts the burden onto crushing academic centers. And the things that did cause the crisis, besides that, are violence. The fact that our world is run by people with poor social emotional regulation. I mean, I don't know what to tell you, like, they did not do well in pre-K. I don't even know if they went to pre-K, they got kicked out of pre-K. And somehow or other, we've created a group of leaders that are bullies. And so if I want to win, and I'm a kid and I watch this, I think it's a good idea to be a bully, right? This is a really depressing map. The Violence Project actually tracks the number of school shootings. So that's the exponential increase in the number of kids that are injured in school shootings since 1966. And as you can see, there's a lot of hot spots for this, right? So, and you heard one of the kids in the Georgia thing say, I'm scared of school shootings. So how many of you went to high school? Great participation, thank you. How many of you remember what you were worried about in high school? What?
Grades, boys.
Okay, yeah. Grades, boys, whether or not you were going to get a car, if you were lucky enough to get a car, how fast you were going to run or swim, or how good your art was. You didn't worry about getting shot, right? So I have a 20-year-old daughter who goes to the University of North Carolina, despite the fact that both her parents went to UVA, which is an issue, although it is way less expensive too. And no, she did not get the cash, despite her asking for the difference. There were 2 active shooters on her campus last fall. Now, she knew what to do. She barricaded herself in a room with her friends and was texting us. And I was like, that sucks, right? That she's a 19-year-old who knows how to hide from active shooters in a library on her college campus. So for those of us who think about the brain, imagine trying to learn in an environment where you are thinking, there's a chance someone can come in here and shoot us all. So the prefrontal cortex and the amygdala, they're battles, right? So we are activating and we have a fear pathway activated, but we're constantly on alert. Makes it really hard to learn, right? And our kids are actually saying this, right? So this is a study that was published that talked about associations between concerns about school violence shootings and clinical symptoms, right? So this is a real feeling. And it turns out putting metal detectors in front of schools doesn't make it safer. You know what makes it safer? Locking up guns. It does. If you lock those suckers up, it's hard to shoot people with them. And you'll see that there's race differences, but certainly everybody has increased risk of internalizing disorders in particular because of this particular fear, right? This is the most depressing part of my talk. It'll get better after this. This is a paper that was published in JAMA in 2023. And what this is showing you is the lovely decline in all causes of mortality for individuals ages 1 to 19 until about 2014, when you start to see it go up. What does that mean? That means that the risk of dying between the ages of 1 and 19 is now increasing in children since 2014. What is driving that? Suicide, homicide, and accidental overdoses. And what I want to point out is that these are not all equivalent. So our suicide rates are substantially so much so that you can actually plot this without adjusting for the rates in the American Indigenous populations in terms of suicide. You'll see that the odds of getting shot if you are Black and killed is also exponentially higher. The only place that things are kind of evening out is this exponential increase in slope and overdoses, mostly from opioids laced with fentanyl. So we are literally killing a generation of kids. And we've wiped out in the last 2 decades all of the medical advances. This is what I tell the cardiologists and the neonatologists, which is probably not a nice thing to do, but I need them to pay attention to, which is that lovely that downward slope of mortality was due to all of our advances in medical care, cancer treatment, care of kids with cardiac anomalies, congenital malformations, the survival out of the NICU, right? All of those things are really great and magical and wonderful. And these other things have wiped out that overall effect on child life. So what are the priorities that we need to pay attention to? Mental health, right? We need to lock up guns. And we need to really dig in and address inequality and marginalization. So 50% of children experience violence within their homes or schools, 1 out of 2. This is not rare. Exposure to community family violence is associated with problems with self-regulation. Thank you, leaders of the country. Changes in attachment and neurobiology. Black youth are exposed to more weapon-related violence and are more likely to be exposed to multiple forms of violence. They are also, unfortunately, more likely to experience discrimination. And all of these things are magnified when we add on social economic inequality. So where did this all start? It started with racism, and the legacy of racism is embedded in redlining. Okay, so this is a map over here of New Orleans. This is the Crescent City. And this is the areas where you didn't want to get a mortgage, right? And this is a mortality gap of about 25 years. That was done in 2019. So we have a 25-year mortality gap. The distance from where this red circle is to here is about 3 miles. That little circle is the same area that was redlined in 1939. This is stop and frisk police rates, and this is domestic violence calls. So objective evidence that these areas are still peppered with violence and continued inequity that is leading to a mortality gap. This is the heat map of crime in the same area, and not surprisingly, overlapping with things like low birth weight. This is not unique to New Orleans. This is the same redlining map of Boston. Oopsie, go back because that's. And you'll see that same area is where concentrated poverty is, concentrated disadvantage, and the inverse, which is concentrated privilege today. So how do we think about this? So when we think about kids, we go back to Bronfenbrenner, who I now can say the name of, right? Because we have to be thinking about where those buffers are and where the stressors are, right? So clearly we have to treat the children. We have to figure out a way to make them feel safe in school. And we have to think about their immediate environment, the household and family. We have to think about the connection, that social connectivity. We also have to think about the social and cultural values that our kids are growing up with. And then we have to think about the entire system. And I'm going to introduce a couple of these theories or sort of concepts of income inequality, right? So this is the difference in your income within your neighborhood based on whether or not you are of a particular race, right? Social cohesion is a concept that relates to how well you feel your group supports you and that you are a part of it. Collective efficacy refers to this concept that if I'm in my group and in my location or home or wherever I consider my place, that I have the capacity for change. And then perceived safety is just that. It's when I'm in my home, when I'm in my neighborhood, do I feel safe? When I'm at my school, all right? So this is speaking to the association of objective data related to neighborhood violence. So neighborhood violence, we think of assault. We think of use of guns and violent crimes. We think of battery. And you can get objective data for this by zip code, and actually map it blocks. And what you see is that for kids that are exposed to neighborhood violence, they are more likely to feel worried, anxious, or nervous, or depressed on a weekly basis, and they are more likely to delay or forgo getting mental health. So even if we had a system where they could access it, the simple fact that you live in a violent neighborhood is making you more anxious and less likely to get help. This is a meta-analysis that actually looks at are psychotherapies less effective for Black youth based on objective data on where they got their treatments related to structural racism. So this is actually using things like income inequality in the neighborhood where their treatment was occurring. And what you see is that if you are in a place with high racism, you're not getting better. Okay, so how many of us think about that when we're doing treatment? Right, so the neighborhood where someone lives in is really, really important. And unfortunately, currently, our evidence-based treatments don't address that, right? So we know that racial socialization is a very important and effective factor. Unfortunately, I can't be very good at that because I am a white woman of privilege. So my voice is kind of annoying, actually, when I talk about it, especially to adolescent youth. They're like, really? What do you know? Nothing, but I have stickers, which also doesn't help adolescent youth, right? So we really have to be thinking about that, and we have to be open with it. And if we are coming from a place of privilege, we have to own that our voices sound different. And we have to recruit more people that look like the kids we're treating, that live in the neighborhoods that are experiencing these things for us to be effective. Okay, so this is work by one of my colleagues in the Violence Prevention Institute, Samantha Francois. She's actually now up in Massachusetts. There's been a little bit of an exodus. And what this looked at was the influence of racial violence in neighborhoods and within the school on externalizing behaviors and youth of color. And this is the pathway. So if you are exposed to racism and discrimination at the personal level or at the structural level, it changes your fear pathway, right? It challenges your sense of self-worth and can lead to psychological symptoms, right? We have the power to have potential buffering or exacerbation by the community as well as the family environment. So this is where a huge buffer for racial socialization, particularly for youth of color who have male mentors. But you may not be able to get that, right? So decreased ability to cope, increased internalizing, and then elevated risk for externalizing. So what she looked at was what else might be helpful. And so what you'll see is that if you are in an area, and this is with high neighborhood discrimination or school discrimination, youth of color were much more likely to exhibit aggressive behaviors. And that makes a lot of sense to me, because if I am worried about being treated differently, if I'm worried about being considered a criminal, I am scared I'm going to get shut up. I'm going to be on edge, and I'm going to be much more likely to be like, hey, back off, right? What was particularly important was the increased civic engagement. So finding a way for these youth to be engaged and feel like they had an important role in their community decreased that relationship between discrimination and aggressive behavior. So giving collective efficacy, helping people have the capacity to feel like they have change in their environment, decreased the fear pathway, right? Think about it. It makes neurobiologic sense. Locus of control, we talk about it in anxiety all the time. Give someone something that they have control over. I can make a change in my environment. I can make a change in this. I can't stop racism because that's a you thing. That is a you thing that you have to deal with, but I can make my community stronger and safer. Okay. This is magnified by immigration stress. And I bring this up because Massachusetts is a sanctuary state. So we have huge influxes of immigration. We'll also say it's a huge target currently of political craziness. And if you are worried about immigration and you live in an area that has more community violence, you are much more likely, so this is low community violence, right? And high immigration worry, you're still upset. But the protective factor of not being worried about your immigration status is wiped out if you live in a neighborhood that is characterized by high violence. So unfortunately, where do we tend to try to help people have housing who are immigrants? In Massachusetts, we tend to put them in areas that are characterized by high violence because it's cheaper, because it's redlined. Okay, so we are perpetuating this, and for immigrants, it's magnified. So as part of the Violence Prevention Institute, we actually looked at this in little kids too, because you know how I feel about little kids. I really like them. And this is work that was led by Julia Fleckman. And we said, what is the impact of neighborhood violence, but also collective efficacy on infant and toddler development? So this is actually looking at 36-month-old infants. And so what we saw was that parent-child attachment was associated with neighborhood violence. So if you lived in a neighborhood characterized by violent crime, you were less likely to have secure attachment. But if you lived in a neighborhood with low violence, you're more likely to be securely attached. And that was also associated with parent perceived safety. So the safer I felt in my neighborhood actually overrode whether or not it was violent. So if I could develop collective efficacy and feel safe in my neighborhood, I was more likely to develop secure attachment. And since I grew up under Charlie Zena, that means everything is better. High perceived unsafe neighborhood and low collective efficacy led to not only decreased attachment, but also lower sort of capacity of the toddler to do toddler things. So they characterize this as protective factors, and protective factors in toddlers are trying to do cool things, asking for help. You guys are all imagining, I'm actually imagining the stage children right now. And they're like throwing stuff everywhere. It's really great in my head. Right? And lower regulation of that child, right? So we know that that parent-child relationship is super important, particularly at this age range. And it turns out how safe the parent feels and how powerful they feel in their own community is part of that pathway. Which also suggests if we're thinking about not just doing stuff at the individual level or the dyad level, we could potentially be thinking about how do we help communities. See, it's getting brighter, right? At least a little bit. So that is the behavioral piece. Now we're going to talk about the biology. So you guys have all heard about this ACEs study, right? Oh, thank goodness. Very bad study design, right? Retrospective, doesn't make any sense. Then stupidly replicated. Dunedin replicated it with retrospective and prospective report, still makes no sense. What it did trigger was an interest, in my case, in understanding aging. Why would that be the case? Because all of the conditions that are related to adverse childhood adversity are actually age-related illnesses, cardiovascular disease, obesity, substance use. We don't have toddlers with substance use yet, right? Diabetes, cancer. Those are all age-related disorders. And what happens with ACEs is they actually are earlier in onset and they're harder to treat, which leads me to Steven Spielberg, who was really good at putting images of his creatures throughout his movies. So this is Yoda, right? So you guys all know Yoda. Please say yes. Yes. Right? So Yoda's 900. Now he looks 900, but he's literally 900, right? Who's this guy? Gizmo, right? What happens? So Gizmo looks a lot like Yoda. Don't you guys see it now, right? So what happens if you keep Gizmo up too late and you feed him? Accelerated aging, and he looks just like Yoda with big eyes and sharper teeth, right? So this is an example of great marketing and accelerated aging. Okay, so one thing that has been looked at is we have ACEs, right? We have these 10 things that make no sense. And then people were like, well, there might be other things that also make no sense that cracked onto this. And one of them turned out to be community violence, right? So community violence actually has the same, if not greater effect size on the risk of depression, anxiety, and PTSD as child maltreatment, right? So how many of us ask, have you ever seen anybody shot or killed in your neighborhood? I mean, I do, but I lived in New Orleans for a long time. It turns out that's really important, right? But understanding community violence as another place of unrecognized trauma is really important. So when I wanted to get at the underlying mechanisms associated with this accelerated aging, I said, well, what are the things that respond, right? And so those are the stress response systems. So the cellular stress response system is one thing I study a lot. Mitochondria and telomeres, you're going to learn everything you've ever wanted to know about telomeres. But it's the first of our many different stress response systems because we start as a cell, right? The next developing stress response system is actually our autonomic nervous system. And that's because in utero, babies are having autonomic regulation. They're actually regulating mom's autonomic nervous system. They can actually wake up mom. My daughter did all the time. She still does. But right, so it's the earliest developing of our stress response system. The next one is the immune system. So we all have had that wonderful experience of staying up too late studying and getting sick or cold term, right? So the immune response is a stress response. The next one is that everyone's favorite, the hypothalamic pituitary adrenal axis, that we have more stress response systems than just that. The last developing one is actually the hypothalamic pituitary gonadal axis, right? Best example of that is what happens to girls who are super stressed and anorexic. Shuts down your menstruation, right? Turns out if I were to put you through a social evaluative stress test, like the Trier social stress test, or just stare at you. For a while, not only do you generate an increased sympathetic tone, in about 10 to 15 minutes, she'll generate a little bit of a cortisol peak. At the same time, she's also going to generate some testosterone. Okay. Then you're going to be powerful and big. Yeah. Obviously, it can help you and really snacking later. Right. So what we think about is that these adverse childhood experiences are actually shifting or accelerating the development of the stress response systems earlier, right? So what does that look like? So it's saying that these stress response systems have to be activated and they have to respond to this adversity. And so they're going to accelerate in their terms of development. But then we create a very unstable Jenga tower, which bothers me a lot, right? So the building blocks of the brain, as well as the building blocks of the stress response systems, need to be built on strong foundations. And if we shift one, we make everything a little bit more wobbly. What's the data for that? You say, ha. So we start with telomeres because they're super cool. They're the aglet cap, which is that fancy word that I didn't know before I started studying telomeres. That's the little plastic shoelace thing. Now you guys all have a new word for your crosswords. And it's an established biomarker of aging. It is the thing that is there because DNA polymerase can only go one way. And it is highly conserved in yeast all the way up to humans. The sequence in rhesus macaque is actually identical to the sequence in humans. So it obviously has to do something. And so it's an established biomarker of aging. And it's also tied very strongly to multiple social determinants of health. We did a meta-analysis that's linked to SES in children, interpersonal discrimination, socioeconomic strain. We actually saw racial disparities in newborn telomere length and also in the placenta. So suggesting that it is tracking onto all of those same ACEs that we thought about. And this is work that we did in the post-Katrina world. You'll see that lovely spot in the middle. That's another, that's the 9th ward in New Orleans. This is a dental study. So these were all the kids that we recruited as part of a dental study. They're not for psychopathology. This was Catherine Thiel, who's one of my dear friends. So always work with your really good friends. It makes the work so much more exciting. And this was just a cool picture because she decided to take on neighborhood transformation as an intervention. What we saw in those youth is that same thing we're talking about at behavior level. So these are kids 5 to 15. We said, Mom, how safe do you feel in your neighborhood? And it was associated with shorter telomeres in the kid, that perceived disorder, and then the objective measure, the percent below poverty. So living in an area that was characterized by objective data and poverty was shortening telomeres, this biological marker of aging that is linked to cardiovascular disease, hypertension, all of those same ACE things in kids ages 5 to 15. This We also looked at cortisol, so the activation of the HPA axis. So we brought these kids in, we had them do a social stressor test. It was usually harder in my RAs than these kids who were like, well, we're fine. But what happened was that the domestic violence rates and the violent crime rates within 1 mile radius of the child's home flattened their expected cortisol reactivity. So we now have evidence that there is a change at the cellular response level and a change at the level of the HPA axis. It also, these same measures were associated with elevated externalizing by parent report. Unfortunately, those pathways were independent, meaning that they didn't mediate each other. So the changes in telomeres didn't predict the HPA axis response and didn't predict the externalizing response, which makes me take a breath, because that means that if I'm treating the externalizing, what am I leaving behind? The altered stress regulation and the altered damage to the telomeres. Right, so I can treat externalizing because I can ask about it and see it, sort of, maybe, on a good day, but I don't know anything about the biologic pathway. What we did see in terms of the mediation pathway was this same domestic violence was associated with BMI and obesity. And in this case, telomere length actually was a strong mediator. So we counted to 40% of the variability. So we see telomere length actually influencing the risk of obesity in kids based on the level of crime in that child's neighborhood. So this makes it hard for me to think about an intervention that doesn't target neighborhood for childhood obesity, which is also part of our epidemic here. Okay. That's BMI month. Okay. So what about intergenerational effects in older youth? So this is work by Susan Moody, who is awesome. And with this is that same cohort of kids, but what she wanted to do was to look at that relationship between mom's exposure to her own experiences of discrimination before kiddo and how well that influenced this really important coupling between testosterone and cortisol. Remember I said she's having some testosterone going? Yeah. So they're tightly coupled. And that coupling is really important for managing and also for deregulation. So controlling cortisol is also linked to how well you are able to couple testosterone, right? So in addition to that negative feedback loop that's implicated by FKBP5 and all of that stuff related to PTSD, this is another pathway to regulate that core response. So she looked and said, what is the relationship between mom's experiences of discrimination and this coupling in youth? And so what we saw, this is just talking about how they upregulate and they control each other, so influence each other. This is the fact that we looked at both the regulation across the diurnal pattern as well as the reactive pattern during the social stressor test, and we saw the effect during the acute reactive, not the diurnal pattern. So it's the reactive pattern that we see. And what you'll look at is mom's report of her own exposure to high police encounters, so increased stop and frisk and increased sort of police-related discrimination. Decoupled, so this is what it should look like. So this is the log of cortisol and testosterone. So you have less cortisol, you have less peak of your cortisol. This is what it's supposed to look like. And what you see is a decoupling if you happen to have high testosterone and a high police exposure in your mother. So changing the regulation of the interactions of those two systems in youth. Great work by somebody with an RA in my lab, who then went on to get her PhD in clinical psychology, and she actually is a clinical psychology. I'm so excited. But she ran the first one of our studies. This is her work in her doctoral program, and what she was able to see is that family social support actually buffered in 3 to 5-year-old children of color the relationship between mom's ACEs and increased externalizing. So mom's feeling of having support was a buffer, right? So going back to that, like, same idea of how do we help? And some of that is going to be at the individual level, some of it be at the dyadic level, but having her identify sources of family support. So, and having whoever's student COS, like understanding that, right? So mom power, another great intervention that deals with understanding social support. But this is buffering the intergenerational transmission of mom's own adversity to externalizing in her kid. This is also great work by Kate Humphreys, who was did her her infant mental health postdoc with us at Tulane. And what she looked at was the impact of attachment security. So the development of a secure attachment relationship actually buffered. And so this is the relationship between mom's own exposure to child maltreatment, right? So you see increased total problems in kids, but if you were securely attached, you were able to buffer that relationship. So the idea that the family support as well as the attachment relationship are critical buffers for the impact of maltreatment and adversity. So where does this leave us, right? So to prevent and cure, I do think we're going to get someday, I'm going to be able to say we're going to cure something, right? Someday, not just talk about the recurrence risk, but we have to shift the whole system. We cannot continue to be in our ICU mentality, right? It is at the level of a population prevalence that there will never be enough of us and we do not have enough hours in our day and we would all just crumble, right? So we have to start shifting the system. And to do that, we have to encourage people to take on these neighborhood level factors that are driving it. We have to build collective efficacy and we have to value social support, right? And really go after risk reduction. And we can't not do this. Right? People always have job security, I promise. We are not going to eliminate our work. However, if we want to be able to be truly impactful, we have to start thinking about how we shift the system. What is our role? Our role is to be out in the community, right? Because if we can get out there, if we can identify these kids before they've been struggling for 10 years, we are the holders of that information. We understand. And I love pediatricians, we work with them a lot, but they have 7 minutes to identify if the kid is offline, right? And they don't have the time to do that. And so we have to build the capacity to see that, and then to get in early, and then to help parents literally be parents, be present, be attached, to listen to their kids. And we have to shift the whole system, right? So this is what we do. Huge amounts of intensive services and specialty services, a little bit of consultation to pediatric practices and schools. But we have to begin to really think about community-based wellness, getting in before kids are sick, thinking about how we promote wellness, right? At the level of families, at the level of communities, and how we play a role in that. So where do we go from here? Every level of training has to talk about structural racism. We have to vote, just vote. We have to take an active interest in understanding how we can adapt our evidence-based practices to integrate effective interventions for structural racism, right? And we have to make sure that we're capturing this in a culturally validated way for all of the different populations that we treat. And we need to be thinking about how do we co-create this with populations, right? So we can't just be like, we've got it figured out. I do not have it figured out, right? I have to own that. And then all of our intervention work needs to effectively consider and integrate considerations of the social determinants of health, right? So it's not just can you get to me, it's can you get to your medicine, can you get food? Because I really think it's impacting our efficacy, right? And because I don't want to end on sadness, there is someone that says it's a lot better than I do.
Can't make a difference. I am a dumbass derelict from Doylestown. And I have managed to change a little part in my little world. And thank you. There is so much to be done. I don't care about your politics. I care about your kids. I care about decency and humanity and kindness. Kindness today is an act of rebellion. There are people that don't have what you have. Help them get it. There is a planet that needs help. It feels good to help. It feels powerful to help. Stop fighting each other and help each other. Get together with your friends and change the f***ing world.
I'm asking. But I do think there are a lot of really important things in there, right? So what do I ask of you guys? Be kind, right? And be kind when you are not in the mood to be kind. Demonstrate social emotional regulation and value other people that demonstrate it. And don't value people who don't demonstrate it. And I think the other part of this is think about what you can do, right? So it's also disempowering for us. We feel like we are swimming upstream all the time. Like there is always 20 more kids in my ER, right? But what is it that I can do? What is it that would be fun to do with somebody else? And those are the steps that we need to start taking. And with that, I think I'm done. But this is really fun, but we can do this later again. But yeah, so I'm happy to take questions. Yeah.
And that, perhaps a few years apart. We hear the kids experiencing racism in their schools and their neighborhood. By whom? Like their fellow, or, like your point was like they're in these neighborhoods that are violent, and where's racism coming from their school?
So I'm going to repeat the question for the people. So where is the racism that these kids are experiencing? And so there's two different measures of it. So one is the child's own report and the mother's own report of their experiences of racism. So there's a measure called the experiences of discrimination that gets at gender, it gets at race and daily experiences. So one example is if you are a African-American boy who's over the age of like 4 and you happen to wear a hoodie and you go into a grocery store, you will be watched. You will experience a threat just because you happen to be a child of color. And if you have the hoodie over your head, like literally in New Orleans, we teach our young boys not to have the hood over their head because that is a sign, right? There was I did some work with the police in Florida. They shot a kid who was running because he was running. And he was a track kid, but he was wearing a hoodie and he was Black. So that's where they experience it, right? The other measure is these objective measures, right? So this is looking at the income inequality. So taking data from the community in which the child lives and looking at the total income of individuals that live in that neighborhood who are Black versus white. It is also looking at the number of households that are Black that are below the percent of poverty versus white. So those types of structural inequities are also part of those experiences of how we characterize discrimination at the societal level. Mm-hmm.
So I'm interested in whether we looked at suburban or rural communities versus inner city, where I grew up in New York City. It's interesting because everybody hates everyone else, but they have to be near each other. They're in the subway together, they touching each other. And I just wonder if that promotes more violence or sort of more acceptance, and how it's different than in segregated. In Los Angeles, I find it's a lot more segregated racially than where I grew up, although it doesn't mean that people are more accepting. But when I got on the subway to go to high school, I lived in Queens, went to high school in Harlem, actually, high school of music and art. I had to travel through so many neighborhoods with so many different people. And yeah, I mean, I was afraid, but I wasn't afraid. I was afraid of anybody who was like touching me, or anybody who was, following me, or anybody who was hustling me. Because I had to walk through a park when I got to the end of my station. I did get hassled sometimes by little groups of African-American girls, but I wasn't afraid because they weren't threatening me. They're just like, got a dime, got a cigarette. So I'm kind of wondering, because it's a very mixed bag, and we live in Santa Monica now, which is a rather segregated city in some ways, although in Santa Monica High School, in the northern part of Santa Monica where we live, it's a yoga town, you know, mostly white, Asian, you know, but people who have a lot of money for the most part, those sort of, you know, people who have advantage. In the southern part of Santa Monica, like near, as you go south, you go a mile or two south, the race, the ethnic percentage changes. It becomes more African American, Mexican American, or Mexican or other. And when you go to a high school like that, like my kids did, I don't think they were afraid, although I've learned that there are things to be afraid of. There's some gang activity, which at first I'm like, no, there isn't, but there is. And there were fights in my kids' classes sometimes, and teachers, but they weren't particularly racial fights.
So I'm gonna stop you because they actually are, right? So part of this is a really important thing, like the generational structural disenfranchisement of minoritized populations is embedded in all of those places, right? And so I want to say that the racism comes from the perception that it's automatically in your head, which is the color of the gangs, right? The racism comes from our own implicit bias that is embedded in every picture up on the wall, that is embedded in every advertisement. And so those areas that are segregated, if you could live in a community that looked like you and never have to leave it, that's the strong collective efficacy, right? But you have to leave that neighborhood. You have to go to another
city communities.
So I can honestly say I've not done any of this work in the rural population. And so I will own that I do not know that. But the amount of segregation is intricately tied to the structural racism that built it that way, right? And what you were describing is that LA has the same thing that Boston has, is the same thing, right? So the reason you have a white upper class yoga group is because it was easier to get mortgages. It was easier to do that than the area that is plagued by violence. It is because that area is able to pay more to go to schools because they have higher people of income, right? So it's that perpetuation over generations that has created that. And so racism occurs in every one of the interactions that you're talking about, and that's on us.
I don't disagree at all. I have sort of a personal / philosophical question for you. What's sort of your perspective on sort of the, part of this academic subspecialty system that, obviously oppressive, and sort of, it's sort of the change from within versus leaving the system to do something elsewhere question. It's something that I struggle with, that I think comes up here a lot for many of us.
Yes, I spend a lot of time saying that my voice is terrible because I am a white woman of privilege.
In an
academic tower. Like I went to the biggest one, right? Like if I could have had more, like if I could have picked somewhere to come, I actually did ask not to be a Harvard faculty because I was worried very much about that. So I think what I do is I come in very humble. And so I did a lot of work with health disparities in breastfeeding and in Louisiana. And what I learned was I needed to pause and listen. Right. And I need to hear the stories, and I need to have a troop of I needed a troop of Black grandmothers to help with my message. I had to hire a team. And what I learned by listening was that the origins of racial disparities in breastfeeding in Louisiana are because our doctors are racist, and because grandma, when she sees you breastfeeding, thinks about slavery. Right. And none of my marketing and none of my messaging touched that at all. Because if grandma says you're breastfeeding, you are just like my grandmother who breastfed white babies, so you're perpetuating slavery. It is super hard to continue to breastfeed, right? So I think for us, it is about being humble. It is absolutely about supporting and differentially investing in anyone that comes into our field that is not a white woman, right? Like I don't need anyone investing in me. So it is finding, seeking, supporting, and then sometimes staying out of the way. But we have to be super intentional about that. And I think it is also about going into these communities and listening and hearing the narrative and that story, And again, something we can do, no one else can.
Question, I think the question stuff included in a way, which is kind of that weathering effect. As you mentioned, the different systems in terms of stress and, you know, as someone who came from a low-income background, it's, you know, here, it is something I worry about, and I was curious if you had a sense of what do you think is behind that effect for people who kind of change kind of socioeconomic strategy.
So I'm gonna kind of address this in three ways. So the first, the Arlene Geronimo's weathering hypothesis, I don't know you guys on that, if you know about it. It's so this multi-generational that structural racism has created an accelerated aging or weathering, particularly in African American women. And there's a clear indicator, which is preterm birth. So it turns out that preterm birth is the biggest predictor of preterm birth, right? And so the idea that if you are a woman of color, the time period at which you experience the most direct discrimination happens to be when you're pregnant. And the vast majority of it happens in the medical setting, right? So we created this cycle. We have not been able to address it. So in the South, if you are a college educated woman of color, your morbidity and mortality is actually higher than an uneducated white woman in terms of perinatal outcomes, right? So that's depressing, and I'm sorry. We haven't touched it, and it's a gigantic problem. I actually think it is tied to accelerated aging, because have you guys ever heard the term wimpy white boy? Okay, so this is what we call little preterm white males in the NICU, because they did terrible. But the babies in the NICU that did the best were preterm African American girls. And so for me, this idea that they were preterm, they were coming out prepared for and older, right? So I think that one of the challenges with this weathering is this pregnancy related, we're starting out a little bit older, right? So there is a not so happy study by Jean Brody that looked at African American college boys and their ability to self-regulate and to excel was actually inversely associated with cellular aging, suggesting that my capacity to control my anger at things like racism, which helped me succeed, was actually causing sort of biologic stress. So with that sad, depressing thing, there are lots of things that we can do to buffer that, right? So stress regulation, exercise is a wonderful, powerful mechanism. Nutrition, right? So the things that will accelerate it, don't smoke, just don't. But like smoking is a great example of a modifiable component of our environment. Building collective advocacy, right? So this is where I think these peer groups for youth of color are incredibly powerful. You being who you are and talking to any teenage boy, hugely protective. And so that I think is this, and also like really fun because you get like a lovely dopamine burst, which is also super protective, right? It's the feeding forward. So the more we are able to do that, I think it's also highly protective. So sadness, goodness.
In relation to that, I know you mentioned how matched like provider race to patient race can improve care. Sometimes I feel like I run into the issue where because I'm not at that socioeconomic status, they'll say the same thing they may say to my counterpart that you don't get it. So has there been any research shown like looking at, I don't know, I feel like as a doctor, I might not be able to make as much impact as maybe a pastor or somebody who's like actually lives in the community. I would just put that out. I'm just curious if there's been any research in that differentiation.
So I think, so a couple of things. So one, thank you for all you do. So very much appreciate that. And so the first is absolutely the pastor, the mother, anybody that is in that community is going to have a stronger voice than us as doctors, right? And there's actually been some great work done by Vikram Patel, actually using community health, like just people in the community and training them to do behavioral activation for depression, and it's incredibly powerful. So it's created an app. It's going to be released for adolescent depression, and so Tammy Benton has been part of the creation of this, using community health individuals and training them on behavioral activation to disentangle like the treatment of moderate depression, right? So absolutely. And I think if I could create a troop of pastors, that would be really amazing, right? So we need to build that. So, and we're going to pilot this, it's called Empower. You can look it up at different hotels, but it's an app. And it's a training app. It's 40 hours. You train community health workers or people or whoever. And then they deliver it, and you can track symptoms within the person that's getting it, and also fidelity to the intervention. So they have built this for adolescent depression. And so hopefully we'll be able to pilot that and see how it does, right? But I absolutely agree that I think even just being, you are a woman of color, but you happen to also be a doctor. And that makes your voice have the doctor sound, right? I own that when I walk into a room. And I think just being able to say that, like I don't have any idea. And despite having some similarities or sharing some background with you, I'm not you. Is really powerful, because it's also saying I want to be humble and listen. But yeah, there are opportunities for that, and I think that's also part of our jobs, is to figure out who those people are, because I think in the Methodist Black Southern society, it's absolutely a posture. So we need to do that for corporal punishment. Turns out Louisiana legalized how to hit children in school. There are laws in the book in 19 states. Yeah. There's 19 states in the United States that actually have laws on how to hit kids in school. Yeah, so corporal punishment is a thing, not here, but real. But we had to go into churches to address that. Oh my God. Yeah. Sorry. Not good. Yeah. Okay, question? You guys want to see something really cute? Yeah. Okay, good. I don't know if there's still people online, but so it's Mattel, but it's Barbie. So
You guys want to do
strawberry shortcake?
that's not Marina, but hold on.
Oh, that. The poster.
This is not what I was meant to show you.
Let's talk about the dream gap. What's that? It's the gap that comes between girls and their full potential. You see, starting at age 5, girls stop believing they can be presidents, scientists, astronauts, big thinkers, engineers, CEOs, and the list goes on. Why? Because what else are we going to believe when by age 7, we're more likely to think that boys are smarter than us? That's ridiculous. When we are 3 times less likely to be given a science-related toy. That's sad. And when our parents are twice as likely to Google, is my son gifted? Then is my daughter gifted? That's not cool. We need to see brilliant women being brilliant and see how they got to where they are. To imagine ourselves doing what they do. But we can't do it alone. Moms, dads, brothers, and bosses. We need all of you to help. We need to close the dream gap. It's up to all of us.
All right, so super cute. And I will say that it is possible to do this because I sent it to my daughter, and she was like, I never thought that. Mommy always told me boys were dumber. So by surrounding yourself with smart people, your kids will think that only girls can grow up to be doctors. Yeah. And I don't know what happens after that. So thank you guys for staying.